Time now for Morning Rounds with CBS News contributors Dr. Holly Phillips and Dr. Tara Narula. First up, high LDL cholesterol, what's often called bad cholesterol, remains a major risk factor for heart disease and stroke. But a new analysis finds many people are not taking the appropriate steps to keep it under control. Tara, tell us about this new research.
So this research was done by the CDC, and they looked at Americans from 2005 to 2012 to see how well we're doing in terms of controlling LDL, a major modifiable risk factor for cardiovascular disease. Well, the picture that emerged from the research is not pretty. Of the 78 million Americans who are eligible for cholesterol treatment, only about half, or 50%, are taking cholesterol medication. Only 46% are doing lifestyle changes to try to improve their cholesterol, like diet, exercise, and weight loss. And 35% really reported doing nothing. In addition, they found disparities based on sex, ethnicity, and race, so that African Americans and Mexican Americans were less likely to take cholesterol medication than white Americans, and men were less likely to take cholesterol medication than women if they were eligible.
So who should be taking the medications?
So that's really the big question that everybody wants to know. It's still a source of a lot of confusion, even though guidelines were published in 2013. It's relatively simple because now what has happened is that we've grouped people into 4 categories. And if you fall into one of these 4, you should take the medications. Medications are statins. That's what we usually use. The groups are those with LDLs that are greater than 190, so very high LDL. Those patients are people who have had a history of a heart attack, stroke, or have coronary heart disease or angina. And then the 3rd and 4th groups are people who are 40 to 75 years old, who have an LDL from 70 to 189, and who either have diabetes or who have a 10-year risk of some cardiovascular event that's greater than 7.5%.
All right, that's who should be taking it. But Holly, what do we do to reverse this trend of people not paying attention to this?
Sure. Well, Anthony, I mean, there really is a big push to reverse the trend. The U.S. Department of Health and Human Services launched something called the Million Heart Initiative. And the idea behind that is to get 65% of Americans with high cholesterol to treat it by the year 2017. And it's called the Million Heart Initiative because it could prevent 1 million heart attacks and strokes. I think one of the really important things that Tara pointed out about this research is it showed us the high-risk groups, right? Blacks and Hispanics are less likely to be on medications, as are people who don't have regular health care follow-up, right? They don't have a regular primary care provider. So that really helps to show us where we can put resources for patient education and cholesterol management programs. One last thing, people worry a lot about side effects of the drugs, which makes perfect sense. In the grand scheme of things, most people do well on the major class of cholesterol medications called statins. And if you don't, there are, of course, alternatives, and diet and exercise are always best. But I do tell my patients there is no side effect worse than a heart attack. So we always have to keep it in perspective.
A new study from the Journal of the American Medical Association looks at the number of C-section births. This is interesting that we have so many more than the average. You're expecting your second right now.
Yes, my second C-section.
Oh, it is. So why do you think it is America is different than other nations?
Right. So this study really looked at what is the sweet spot where you increase the rate of C-sections, you decrease neonatal and maternal mortality. And previously that recommendation had been 10 to 15 C-sections per 100 live births. Now the recommendation by this new research, based on looking at 194 countries, is that that sweet spot might be about 19% or 19 per 100. In this country, we perform about 33%, or 1/3 of our deliveries are C-sections. That number has risen over the last 40 years from 5% in the 70s to the 33% now. And it's probably based on a number of factors. First of all, our technology has improved. So we have something called continuous fetal monitoring. So when a woman comes in the hospital pregnant, there's a monitor put on the belly. If the baby's heart rate increases or decreases, it may be a sign of what doctors think is fetal distress. That may trigger a trip to the operating room. In addition, there have been changes in obstetric practice. So now if the baby is malpositioned, if it's breech, if it's large, if a big baby, if the pelvis of the woman is deemed small, or if the woman has had a previous C-section, these might trigger another C-section.
You always hear women who've had C-sections one time say they perhaps wanted to do it the traditional manner,
Exactly.
and the doctor told them it wasn't really an option.
Exactly. Well, there's a risk of uterine rupture, and so that's why it is recommended many times to have a second C-section. Other factors, unfortunately, include legal things. So, you know, obstetrics is one of the professions that's at highest risk of being sued. So many doctors may feel, well, I want to do everything possible, do the most aggressive intervention, so that if something goes wrong, at least I can say I did a C-section. Right. And then last is maternal choice. So some women really feel I want control over the timing and the way I deliver, and that's why I choose a C-section.
So, Holly, how big a concern is this higher rate of C-sections in the U.S.?
Well, you know, like with any surgical procedure, there are risks, right? There are risks of infections, anesthesia problems, blood loss, blood clots. And we also know there are benefits to the baby for having a regular vaginal birth. On the other hand, there is a balance. We see in countries where C-section rates drop below 7%, levels of maternal and fetal death really skyrocket. And there are also some really pragmatic reasons why in the United States we see more C-sections. We have more women who are later in life, older mothers having babies, and that raises the risk of C-section. And we also have an obesity epidemic, which also plays into how many C-sections are done. So really there is a balance, and it's about trying to find that sweet spot, but in each country based on what their risks are.
Well, finally this morning, experts say portion sizes may be a key to battling obesity. Did we need experts to study this?
Yeah.
You know what? We know now that how much we eat plays just as important a role in obesity as what we eat.
Yeah.
But one of the really key points is that we tend to eat what's in front of us. So in this study, you know, the researchers pointed out portion sizes have more than doubled or tripled in restaurants since the 1950s, as they have in packaged foods. So the idea, you know, when they looked at this review, they found if you just cut out the largest portion sizes, right? Think supersize or biggie size, or the biggest that you can get. If you only get rid of that level of or that amount of food, we can cut total calorie intake in Americans by up to 29%, which could really change the landscape of obesity. Also, at home, if you use larger plates, larger bowls, you tend to eat more. Basically, what's put in front of you, you will eat. So if you figure out how to put less in front of you, you'll eat less.
Very simple lesson. All right. Doctors Holly Phillips and Tara Narula, thank you both very much. And do you have questions for our doctors? Visit our Facebook page to submit your question for an upcoming Morning Rounds segment.